So the next lecture is from Dr. Eisha Christian. Dr. Christian is a consultant neurosurgeon, pediatric neurosurgeon at the Sick Kids um, at Toronto, and she's going to talk to us about patients with Chiari with hydrocephalus and those with intracerebral changes in intracerebral pressure. Thank you, Dr. Christian.
Hi, everyone. Really appreciate being invited to speak today. Let me just try to share my screen here. Hi, everyone. Great to be here. And that was a really great lecture. I think I know Dr. Narenthiran asked me to include a little bit on the time slip imaging at the end, but I'm mainly going to speak about just the management of hydrocephalus and intracranial hypertension associated with Chiari, and then briefly also talk about some cases associated with intracranial hypotension and what the management pathways are. I don't have any disclosures, and we'll start with hydrocephalus and Chiari malformation. And I know Dr. Limbrick mentioned Hans Chiari, who first described the Chiari malformation in the 1890s. And really, the description of hydrocephalus and Chiari were first mentioned by him. And if you look at one of his first publications in 1891, it actually translates to cerebellar changes caused by hydrocephalus of the cerebrum. So in a lot of ways, this theory of hydrocephalus causing the Chiari malformation, that was the original hypothesis in the 1890s. This came from a case report of a 17-year-old girl with typhoid fever, essentially, and Hans Chiari had done her autopsy and found this caudal descent of the tonsils with ventriculomegaly, and essentially this is where that hypothesis began. So the simple hypothesis, which we all know doesn't fully or even explain majority of Chiari malformations, is essentially pressure from above. However, there are a lot of other things with Chiari that we now know that negate this simple hypothesis. And even though it may be true for a certain percentage of Chiari malformations, if we look at studies, we see that anywhere from 6 to 25% of patients with Chiari malformation have ventricular dilation. And I would say most people say about 10%. Therefore, a vast majority don't have ventricular dilation, and therefore this theory wouldn't hold for the rest of these patients. And then if you look at patients who do have Chiari secondary to hydrocephalus or any other cause of intracranial hypertension, for instance, with tumors, you do tend to see some of this reversing when the hydrocephalus or the tumor is treated. But then again, not all of these reverse as well. And then you have a more complex hypothesis that's been described over the years, and many different theories. Again, not one explanation, but one involves a hypoplasia of the occipital bone that happens during development, which essentially leads to overcrowding of your neurovascular structures, neural tissues, could potentially lead to hydrocephalus as well. And the other facts or findings that you can see that are associated with this are things like basilar invagination, your instability of the upper cervical spine. All of these go along with this hypothesis that there's some type of issue with the actual bone that goes on during development. You see this with syndromic craniosynostosis. That's thought, the hydrocephalus here is thought to be an occlusion of the jugular foramina with a decrease in CSF resorption. And you also see this in non-syndromic Chiari malformations, where this is thought to be more of an occlusion of the actual CSF pathways. And then again, this theory doesn't explain everything, because when you go back and look at Chiari patients, not all patients have a small volume when you look at the radiology and you try to calculate their volumes. So trying to break this up piece by piece, one is looking at patients with a smaller volume, so a cephalocranial disproportion. And I think one classic example is craniosynostosis. If you look at craniosynostosis patients who have Chiari malformation, the two main syndromes you think about are Pfeiffer and Cruzon. And now basically Chiaris have been described in up to 70% of Cruzon patients with craniosynostosis, and in Pfeiffer's almost half as well. But then if you go back and look at craniosynostosis and hydrocephalus, this percentage is much less. You only see about 12%. And then you go one step further, you take patients with complex craniosynostosis who do have hydrocephalus, this 12%, 88% of them do have a Chiari malformation. So again, a lot of things that are interlinked, but not completely explanatory of each individual diagnosis. So going again into the complex hypothesis, one idea is that there's this possible progressive blockade of CSF flow from the cranial to spinal compartments, and there's this occlusion of the fourth ventricle foramina. Now, is it primary? Is it secondary? These can also be debatable, and there's also description of an occlusion of the cisterna magna as well. So to summarize, and again, I've put this reference at the end because I think it's a great paper that summarizes the different hypotheses of Chiari and hydrocephalus. We have the simple hypothesis that goes back to Hans Chiari with just a primary obstruction of CSF flow leading to hydrocephalus, and then a pressure from above theory, which causes the Chiari malformation. Now, the complex chart's much more involved. You can see it could involve this jugular foramina and the neurovascular structures causing venous hypertension that could cause the hydrocephalus, or leading to more of a cerebellar hyperplasia almost, or edema, and leading to, again, a disproportion of your cephalocranial volumes, with overcrowding, again, leading to the Chiari malformation. And then with the Chiari, you get impaired CSF circulation, which causes hydrocephalus. So again, a lot of different pathways, some interconnected, which I think make this a complex problem and difficult to treat, because all these theories don't fully explain the association between hydrocephalus and Chiari malformation. So again, as I mentioned, the challenges then become how do you treat these patients? The chicken or the egg, which comes first? One, we don't have a unifying etiology, so this complicates treatment decisions. You don't have a kind of a simple pathophysiology. There's different variations of Chiari, how they present, severity of symptoms, and again, multiple theories exist. None fully explain the conditions. They are interconnected, and you get variable patient presentations. And therefore, treatment really requires a more personalized approach. So one is the big question: do you treat the hydrocephalus or the Chiari? And I think this is, even though most of us say treat the hydrocephalus first, I think this is still up for debate. I would say most surgeons tend to treat the hydrocephalus first. It's more symptomatic often. It does address the syringomyelia. It eliminates any concerns for high intracranial pressure. And if you treat Chiari, do duroplasty with hydrocephalus in the background, you could get complications of CSF leak and postoperative pseudomeningocele that you would like to avoid. Now, the one exception to think about is syndromic craniosynostosis. When there's an obvious craniocerebral disproportion in these patients, do you treat the hydrocephalus or Chiari? And I would say most would say consider vault expansion in infants and posterior fossa decompression before you manage the hydrocephalus, because the hydrocephalus helps you with expanding volume, essentially. Now, once you decide you want to treat the hydrocephalus, then the question is, do you shunt or do you do ETV? Now, we think about 10% of Chiari patients have hydrocephalus. Now, this is a paper from 2011, small series of patients, but one of the first that described ETV in the management of Chiari 1 related hydrocephalus. And in this very small series, all 15 responded to ETV. Now, since then, 15 is a small number. So looking at this in more detail, there was a systematic review that came out last year that essentially did a pooled analysis of 35 cases of Chiari malformation and hydrocephalus treated with ETV. And they did find about a 66% symptom response and improvement. And then radiographically, there was definitely tonsillar descent reduction, decreased ventriculomegaly, and almost all patients had open ETV. Now, if you really look at the details of this paper, though, there's a lot of variation in patients. Several did need repeat treatment as well. So again, I don't think we have all our questions answered at this moment if in terms of management. But avoiding shunt obviously is great if there's anywhere over a 50% chance of response. And so I think ETV has become a favored method of treatment for this. Now we do have surgeons still doing shunts. And again, this is another paper that came out in the last 5 years, just really a case report on an infant with Chiari-1 malformation, hydrocephalus, with quite symptomatic, and essentially all these symptoms did resolve with a VP shunt treatment, and no decompression needed. So the next step is to talk a little bit about Chiari malformation, hydrocephalus, and syndromic craniosynostosis, because again, this would be the exception to the treat the hydrocephalus first rule. And if you look again at craniosynostosis and Chiari, Pfeiffer and Cruzan are the two syndromes you do see more of Chiari-1 malformations. It's very rare to actually see this in APERT. And then if you look at craniosynostosis and ventricular dilation, again, similar numbers in Pfeiffer and Cruzan, and APERT also having a high percentage of ventricular dilation. But I would say the key difference is in APERT, they're non-symptomatic ventricular dilation, not requiring treatment, whereas in Pfeiffer and Cruzan, the ventricular dilation ends up being symptomatic and requiring CSF diversion at some point. And then the other key, I think, when you're managing these patients is to look at their signs and symptoms that they're presenting with. Are they symptomatic from the Chiari, or are they symptomatic from the hydrocephalus? Now, again, I did mention that in infants especially, most people prefer managing the craniosynostosis first and increasing volume and doing a potential Chiari decompression at the same time. But as these kids get older and have signs and symptoms, it's key to differentiate, are they having high pressure symptoms or Chiari symptoms in your next steps for management. So with hydrocephalus, again, the things to look for, and I know that previous talks have long lists of both of Chiari symptoms as well, but with hydrocephalus, you're looking at drowsiness, vomiting, head circumference increase, and bulging fontanelle, and sunsetting in infants. And obviously headaches in older and papilledema in older children. With Chiari, again, the list is much longer than what I've included here, but these are the ones to consider in being more of a Chiari type problem than a hydrocephalus issue. So treatment, again, in general, most people tend to treat craniosynostosis and then monitor ventricular size. I would say consider ETV as well. There have been some evidence showing that if they're over 6 months, the response rates in this patient population are better. And if there's evidence of foramen magnum obstruction on MRI, then those patients have a better response rate to ETV, but again, very small numbers. And then in shunts, the recommendation is to use programmable shunts because their hydrocephalic needs do change, and especially in terms of developing syrinxes and syringomyelia, there's been some preference for use of programmable shunts, but again, very small amount of data. In terms of Chiari treatment, again, the craniosynostosis in infants with a posterior vault expansion, with or without a posterior fossa decompression at the same time. And I think most advocate early vault expansion for multi-suture craniosynostosis. And then in older children, because of the high risks of vault expansion and delayed diagnoses, you can consider just doing a Chiari decompression. And again, as I mentioned before, lots of challenges with this. I think a lot of these papers have small numbers of patients. And I think there's still more to be done in terms of finding an optimal management pathway for hydrocephalus and Chiari malformation. Now, the next thing I'm going to briefly talk about is Chiari malformation and intracranial hypotension. So this is another theory in terms of the etiology of Chiari malformation. This is a paper back in 2009 that describes acquired Chiari malformation as a late complication of CSF shunting. The theory or the idea is that this chronic removal of CSF leads to an intracranial hypotension, that there's progressive inner bone deposition of the skull. And with this, there's a decrease in skull volume that basically leads to Chiari malformation with downward herniation. Now, this paper describes 17 patients, and now this is out of 1,700 patients with the Chiari. Only 9 were symptomatic, and they did rule out a shunt malfunction as well. But I'm sure all of us have had patients with shunted patients who have developed Chiaris over time when you go back and look through the imaging. And this is again, if you look at the bone, and I'll show some pictures later on, there is this deposition and thickening of the skull that you do see with these patients. That's typical. So this is one case example of a patient that had an arachnoid cyst, no Chiari malformation. The top row here is pre-intervention. Then you see row B, essentially, this is after the patient was shunted. You start seeing a little bit more tonsillar descent. And then rows C and D, essentially, C is pre-op, but you see this again, thickening of the bone, which you start seeing actually in B as well. And you see a Chiari essentially on the sagittal imaging. Now this is post-op because this patient was symptomatic and went on to need surgery and decompression. But again, the thickening of the bone, quite typical. This is another case study. And again, you see hydrocephalus, no Chiari on A. You look at B, you see a dramatic thickening of the bone, slit ventricles. Now you see a Chiari. And then again, example 3, same thing, hydrocephalus in A. Treated hydrocephalus, the tonsils look a little lower, and you see the cerebellar is taking up more volume, and then essentially thickening of the bone over time with Chiari malformation. So management for this, you could do multiple things, and I've again small series of patients that have been described in the literature. I think the typical is to do a Chiari decompression and duroplasty. There's small case series of some surgeons who've decided to do a cranial vault remodeling, but obviously very difficult in older children. And then there's a small set of series describing a Chiari decompression duroplasty, and then essentially a thinning or down of the occipital planum and a remodeling in just the occipital region, with the bone being replaced once it's thinned down. The second example of low pressure and intracranial hypotension and Chiari development is with lumboperitoneal shunts. And again, you have drainage of CSF in the lumbar region, leading to a downward motion of movement of tonsils due to a pressure differential theory. And this has been described with lumbar punctures as well, repeated lumbar punctures. And classically, the management's essentially been the removal of the lumboperitoneal shunt, insertion of a VP shunt, and then if this fails, ultimately leading to a Chiari decompression and duroplasty if needed. I know I was asked to briefly talk about imaging, which I know we had a very detailed lecture on, so I'm going to go quickly through it. But a lot of detail on the cine phase contrast MRI with our last talk. And specifically to talk about the timestamp MRI, looking at CSF motion because this was just published a few months ago. Now, I actually trained with Gordon McComb at CHLA, and I know he was working on this more than, I think, 15 years ago when I was a resident at CHLA and Children's Los Angeles. And essentially, he worked with the radiologist and physicist on a timestamp technique for looking at CSF motion around the foramen magnum and also at the floor of the third ventricle. And again, there's always been an understanding that there's an obstruction of free movement of CSF across the foramen magnum, especially during systole. And the timestamp, I think, takes advantage of this. And again, I think physics of it are a little bit beyond my understanding, but it's a very short protocol. It's about 7 minutes. It's on a 3T scanner, and they ask for fast spin echo sequences that are about 4 millimeters thick. And essentially, there's CSF tagging that's done during the MRI, and it's quite easy to process, is my understanding. They had several case examples they highlighted in this paper, but one was a 15-year-old with suboccipital, again, post-Valsalva headaches. And you can see the timestamp on B that basically shows no flow around the cervicomedullary junction. And I think you can appreciate this on the T2 sagittal as well. But after surgery, there was a complete resolution of the headaches. Now, case 2 is a 3-year-old with a Chiari and syringomyelia who presented with neck pain and bladder complaints. But again, you can see with the timestamp on the pre-op is here in D, very minimal flow, and post-op, 3 months post-op, you can see that there is flow around the foramen magnum and improvement of the syrinx as well. And then case 3 is a 16-year-old Chiari incidentally diagnosed after head trauma imaging. He did state that there was a history of headaches for about 6 months, but given that there seemed to be good flow around the foramen magnum, the decision was made to observe. And when he followed up in clinic, there were no headaches several months later. And so again, just some nice case examples of how this has been helpful. And my understanding is they're easier to acquire than the cine phase contrast and interpret as well. But again, it's just briefly, just very challenging, I think, in terms of the best way to manage these patients. And I think they really require a more personalized approach in terms of managing the hydrocephalus and Chiari. And I don't think there's necessarily one pathway forward, even though majority would say manage the hydrocephalus first, with the exception being in craniosynostosis. Some references that were helpful, and that's it. Thank you.
Thank you very much, Dr. Christian, for that fantastic talk, unpicking the overlay of hydrocephalus and pressure in patients with Chiari, which sometimes doesn't come apparent in the first look because the eyes go to the tonsillar descent. I'm going to ask our faculty for this session, Professor Llewellyn Padayachy. Dr. Padayachy, your comments on the lecture and your questions for Dr. Christian. Thank you.
Thanks, Naren. I think that was just a fantastic overview. The last one and the previous ones by Dr. Limbrick and the radiologist. So I'm going to ask Dr. Christian. I mean, this issue of asymptomatic or incidental Chiari is something we all have to contend with quite a bit. So to what extent, and how do you look, asymptomatic is very different in different practices. So the harder you look, the more you'll find something. So we heard about hydrocephalus, we heard about intracranial hypotension. The other thing is, imaging the entire spinal axis to rule out tethered cords. We heard earlier that some do, polysomnography. To what extent do you investigate your patients, before you call them asymptomatic is my question. No, thank you so much.
So I mean, I personally follow them, not for their entirety if they're teenage years, but they at least get one follow-up a year later. They do get brain and spine imaging as well to look for syringomyelia and a full exam. With the sleep studies, I find our wait lists are quite long, to be honest with you. So it would be very hard to order a sleep study because I do see a few Chiari patients almost every week. So I try to ask them questions about just sleep disorder, any changes in sleep with parents and things like that, and go from there. But I agree. I think it's tough, and I think the headaches are the hardest to distinguish what's really Chiari related and not.
Okay, Llewellyn?
Yeah, no, thanks. Look, that's always a tough one. I know there isn't an answer. I was just wanting to see to what extent. I mean, I've also heard people doing SSEPs, which in an awake patient is really, really unpleasant. So just the extent to which one investigates them. Thanks so much. Thanks, Nam.
Thank you, Professor Llewellyn. Padayachy. Professor Brockmeyer, do you have any questions for Dr. Christian?
No, Eisha, that was a great presentation. I think that the syndromic craniosynostosis population and how it connects with Chiari is really poorly understood, and I really appreciate your thoughts about that and the vault distraction techniques rather than the posterior fossa techniques. So I think we don't know a lot about it, and it's an understudied population. I don't know if you have any other thoughts about that.
I 100% agree. I think I didn't realize that till I went out in practice and I was starting to see a lot of this. And then the issue becomes, are they symptomatic? I think the key is, it's a hydrocephalus issue or this Chiari issue. And I know in some cases I've had to do pressure monitoring, ICP pressure monitoring. But those patients I find, especially Cruzon, can be a lot of variation in presentation. I'm a huge fan of trying ETV as initial management. I think after the vault, because just letting the ventricles get bigger actually helps with volume. And then if I can, I try to reach down and decompress the foramen magnum at the time of the vault as well. And I've had patients do well with that.
Thank you, Dr. Christian. Dr. Jallo, do you have any questions for Dr. Christian? Thanks.
No, thank you. The question, how often do you place an ICP monitor to help determine whether it's ICP versus the Chiari as the etiology for their symptoms?
I think if they're having papilledema, it's I don't necessarily place an ICP monitor because I feel like that's more of a pressure issue. But if I'm not quite sure and they're having combination of both, then I have. But again, it's been a couple, maybe one or two over the last 7 or 8 years, so not commonly.
Thank you. Dr. Rizk, do you have any questions? Dr. Rizk, we had some difficulty catching the sound, I think. So I think, Dr. Christian, did you catch Dr.?
I might need you to repeat the last part, but I think there's just treating maybe the Chiari decompression, doing that first versus the hydrocephalus, and that there's not enough maybe data that we still don't quite understand what the right steps are? Is that, I think that's what I heard, but if I didn't.
Yeah, what I'm alluding to is that treating something will result in a better outcome, be it Chiari first or the hydrocephalus in a hydrocephalic patient, because both entities might end up treating or helping the patient. The paper that Iskandar put out a couple of years ago, showing that in his cohort, the posterior fossa decompression with or without duroplasty tends to resolve the hydro in about 90% of the patients. Is a point I'm making, that sometimes people are not comfortable doing ETVs or putting shunts in off the first evaluation. So you could still consider that as an option. It's not like, it's absolute, especially in the lack of concrete good data, and a call to us as a community to start looking at this stuff much wider patient cohort rather than 19 patients or 2 patients here and publishing it in the literature.
No, 100%. I think that's the big thing. I don't think there's a right answer. I don't think we completely understand it, and it just needs to be studied more.
Thank you, Dr. Rizk. Thank you very much, Dr. Christian, for that really fascinating and insightful lecture. Dr. Christian, there are 3 questions for you on the chat box. Because of the time, may I please ask you if you would answer them on the chat box, please. Thank you again.
Definitely. Thank you.
Thank you very much.